Good evening, everyone. And welcome back to our monthly meetings. Is everybody getting that echo?
Yes, there's a feedback.
Okay. I don't hear it anymore. Is it good now? Okay, that's better. Thank you. Once again, welcome. Everybody had a long summer break, which I hope you all enjoyed. It's certainly been hot enough. Hope you've all stayed cool, stayed hydrated. Good to have you back. We will get this meeting started with our opening prayer. So if we can all just get ready for that. Heavenly Father, we come before you today in humility and faith. We thank you for all you have given us and the many blessings in our lives. We ask for your guidance and strength. Show us the way and fill us with courage and wisdom. Help us to remember your love and grace and to be faithful in our service to you. Give us the patience and understanding to face life's challenges with grace. As we begin this meeting, we ask for your guidance, wisdom, and support that we might engage in meaningful discussion and use the knowledge gained for our own betterment as well as for helping those in need. These things we ask in your name. Amen.
Amen.
So, like I said, good to have you all back. And I see we have almost a full house. So I'm happy to see that. I hope everybody's doing well. So we'll get started with, has anyone had any birthdays or anniversaries or milestone dates, either coming up this month or had it while we were off on break? Can let us know so we can wish you well. Any birthdays, anniversaries, milestones? Anybody want to share? Okay. Well, oops, sorry. I will now ask our administrator, Erin Storr, to update us. Any announcements?
Hi, all. Yes, welcome back. It's September, and everybody used to September being Prostate Cancer Awareness Month. But this year we're gonna switch it up and have ovarian cancer. Now for announcement, give me one moment. I have a presentation. Let me see if I can bring it up. Share screen. Everybody can see my presentation?
Yes.
Okay. All right. Like I say, September, we are observing it as Ovarian Cancer Awareness Month. But we still gonna acknowledge prostate cancer. So, but this weekend coming, we're having a PSA and Pap smear free clinic on the island of Long Island. And we have two doctors heading there, and the clinics would be Deadman's Key and Sims Community Clinic. So please tell persons who are in Long Island, please attend the clinic. It's free, so they can get their Pap smears done and men can get their PSA testing. Like I say, we have Remember the Men, and Us Two Men group is having a free PSA testing for men. And it's going to be September 19th at Elizabeth Estate Clinic, September 21st, Flamingo Gardens Clinic, September 26th, South Beach Clinic, September 28th, Fleming Street Clinic. So the clinics are going to be on Tuesdays and Thursdays. And registration starts at 9, and the clinic, registration starts at 6, and clinic ends at 9. So we, Us Two Men haven't had this from before COVID. So this is probably long overdue. So please let all the men in your life know, your father, your uncle, brothers, anyone over the age of 40, please come and attend one of these clinics and just get your PSA. It's quite simple now. Just a prick of the finger and they can tell your PSA levels. So they don't have to be afraid. Well, even though we're still in September, we have a new shirt design for October and we're getting orders in. So we want to give you a brief preview of what our new shirts will be looking like for October. So these are the new shirts for October. We have men and they're unisex, so they go for both men and ladies. We have them in the pink with the black or the black with the pink. We also have the pink with the white. And like I say, they're both unisex shirts. And the polo shirts are going for $35 for extra small to extra large and $40 for the 2X. Now, because they're unisex, ladies, if you are petite, you would probably take an extra small. And for normal size, you can take a small. So these are our new shirts. And I think they're fantabulous. So get your orders in early. Call us at 323-4441 or 323-4482 and let us know which shirt you want and we can pre-order it. And we're expecting the shirts to come at the end of this month. So within the next 2 weeks, we should know that our shirts are here and for distribution the first week in October. So you can sport your nice Cancer Society shirt on Fridays in the month of October. We also have some super cool leggings. You know, a lot of cancer walk is coming up. You have October 7th, we have First Caribbean Walk for the Cure. And what a better way to sport your nice pink ribbon tights. And they're for $30. And we have them from size small to extra large. And because they're spandex, you can go a size down. We have also the Dragon Boat Racing. This is their second annual event. Last year's event was fantastic. It was exciting, exhilarating, nerve-wracking just to see the competition out there on Goodman's Bay. So come and support. It's going to be September 30th and October 1st. Most of the heats would be on the 30th and then the finals will be on the 1st. But it is very, very exciting. They would have a show afterwards, a performance. And last year they had a Junkanoo rush out. So be there at Goodman's Bay, September 30th and October 1st. All you Long Islanders, the ball is back on. You know, we have been in hiatus for 2 years now. So, you know, we're coming out and we have to wear our ball gowns and get all fancy. So Long Island is having their ball on September 30th at the community center. Ticket price is $125. And if you're interested, there's generally number there, 551-2346. She's the president in Long Island. And contact her and let her know if you're interested or have somebody in Long Island and let them know to come in and participate and support. In Grand Bahama, they have for October 2nd, I think it's October 2nd, I can't see my date. But
yeah, 2nd through the 26th.
Pardon me?
It's the 2nd through the 26th of October.
Yeah, I didn't know it started early in October, but it's the Battle of the Bra. And you vote. And every time you vote, there's a fee of, I think, $5. And it goes towards the Cancer Society of Grand Bahama that helps persons in Grand Bahama when they have to come here to Nassau for treatment, help them with their portacath, or if they need airfare or anything, but support the Grand Bahama Cancer Society in their initiative. They will also be having a symposium. Again, this is in October. So I just wanted y'all to see what's going on and to have it in your minds of events that are happening. We will show the announcements again later after the presentation, but we don't want to take too much time of our guests. So once again, we thank you. And if you're interested in the shirts, like I say, call the office at 323-4441 or 323-4482.
Okay, thank you, Erin. So I guess we will get right into our presentation. I think our speaker is on and ready. So I will now ask you once again, Erin, to introduce our guest speaker, please, so we can get started.
Okay, we have Dr. Saida Bowe. Dr. Bowe is currently a consultant in the Moran Memorial Hospital, Freeport. She recently completed a fellowship in gynecologic oncology at the University of Calgary, Alberta. Dr. Bowe also completed the IGCS Gynecologic Oncology Fellowship, and this program is in conjunction with University of Miami and UWI School of Clinical and Medical Research. Dr. Bowe is currently auditing the management of pre-invasive cervical cancer in Grand Bahama over the last 15 years. She is also a co-investigator to assess awareness of BRCA mutations, cancer risk, and prevention methods among the Bahamian population. Dr. Bowe has previously traveled with the Cancer Society of the Bahamas to the various family islands, assisting with screening. She has chaired the Stride for Life Walk. She has one son who is a junior at St. Mary's University in Halifax, Nova Scotia. And I had the esteemed pleasure of accompanying Dr. Bowe on our last free clinic in Bimini, which was amazing. And without further ado, let's welcome Dr. Saida Bowe.
Good night, and thank you very much, Erin. And yes, it was a great trip to Bimini. So for all those that are present, I don't want to say ladies because I'm not sure of the gender of all persons present. But to all persons present tonight, I will talk briefly on ovarian cancer. And it is my hope that at the end of my presentation that most persons would be aware as to the symptoms of ovarian cancer, along with the risk factors that persons have that would predispose you or increase your risk for ovarian cancer. Ovarian cancer, unfortunately, is the 10th most common cancer in women, the 5th leading cause of all cancer-related deaths, and it is the most deadly of all of the gynecologic cancers. Gynecologic cancers being those of ovarian, uterine, cervix, vulva, vagina, fallopian tube as well. Unfortunately, breast is not considered gynecologic, even though, yes, it is, for the most part, seen in women, but because there are men that can get breast cancer, it is not one of those that is considered to be a gynecologic related cancer. So some statistics. In 2020, there were over 3,000 women diagnosed with ovarian cancer and almost 2,000 deaths. 3% of all cancers diagnosed in women, again, are ovarian. The lifetime risk in the general population is less than 2%. So less than 2% of the general population will actually get ovarian cancer or have a history of ovarian cancer. Because when we look at this pie chart though, however, it's looking at the deaths related to the gynecologic cancers. And we can see that over 50% is related to ovarian, and uterine or endometrial cancers is less than 30%. which in our setting is not a very bad situation, that we have less than 30% of the patients with uterine cancer dying as a result of this disease. Reason that a lot of women die from ovarian cancer is because 75% are diagnosed at an advanced stage. 20% of those with an advanced disease will have persistent or refractory disease even after completion of their treatment. 60 to 80% of our advanced patients will have a recurrence of their disease. So what's the staging of ovarian cancer? Stage 1 means that it's just confined to the ovaries. And yes, we break it down into also including numbers and letters. So subscript numbers and subscript letters. But generally, 1 is confined to the ovaries, 2, it's within the pelvis, 3, again, limited to the abdomen, and 4 means anything that is outside of the abdomen. So patients with a pleural effusion or even liver involvement is considered to be a stage 4 disease. I'm sure everybody has seen this before written, that ovarian cancer is known as the silent killer, again, because of its advanced stage at the time of diagnosis. In the US, however, 50% of persons diagnosed are older than 65. We don't have that luxury in the Bahamas to say that most of our patients are elderly patients that are diagnosed with ovarian cancer. We do have a lot of patients that are diagnosed at a young age with this disease, unfortunately. And this pie chart on the side is showing our local statistics for the year 2020, and this was taken from Global Can. Again, looking at the prevalence of ovarian cancer in the year 2020, there was 25 new cases, and in that year, there were 15 deaths from patients with the diagnosis of ovarian cancer. Now, unfortunately, this is not saying that 15 out of those 25 in that year died. This is just in the year 2020, there were 15 deaths as a result of ovarian cancer, and there were 25 new cases of ovarian cancer, but still a very high mortality associated with the disease. What are some of the risk factors that would predispose a person to, or increase a patient's risk for ovarian cancer? There is a genetic predisposition. Most persons would have hopefully heard of the BRCA1 or BRCA2 mutation. There was a study done several years ago by Dr. Curlin, Dr. Turnquest, and the team out of the University of Miami, looking at the BRCA mutation among the Bahamian population in relation to breast cancer. And from that study, we know that we have an almost 23% BRCA mutation within the Bahamas. While it was a small sample size, that is still a very significant number for us. And there are particular mutations actually that are specific just to the Bahamian population. One mutation is actually seen within the African community a community within Africa. Another genetic predisposition to ovarian cancer is hereditary non-polyposis colorectal cancer, or more commonly known as Lynch syndrome. Persons with this syndrome actually have a predisposition to colon cancer, endometrial cancer, and also ovarian cancer. Your risk of developing colon or endometrial cancer is higher if the patient has Lynch syndrome. However, there is a 20% risk of ovarian cancer if the patient has one of the mutations associated. Another risk factor would be that of a strong family history of breast or ovarian cancer. So is it that the person has a first-degree relative, being that of mother, father, sister, or brother with breast or ovarian cancer? Hormonal factors, they also play a big factor in risk of developing ovarian cancer. Is it a patient that has never had a child before? This also increases your risk of developing ovarian cancer, early menarche, late menopause. These play a factor. History of endometriosis. Patients with endometriosis have approximately a 2% risk of developing an ovarian cancer. Now, there is specific ovarian cancers that you can get as a result of endometriosis, those being the endometrioid type or clear cell. Those would be the more commonly associated with endometriosis. So we talked about the BRCA or BRCA mutation. The lifetime risk in persons with this mutation of developing ovarian cancer is up to 40%. And this is compared to an almost 2% risk in the general population. So in persons that have the mutation, sometimes discussions are had with the provider to discuss risk-reducing surgery. If it is that this patient has a mutation and has completed their family. At least 1 in 5 women diagnosed with breast cancer have a mutation in BRCA1 or BRCA2. As I said, we have a 23% BRCA mutation. So what are some of the things that can protect you actually from developing ovarian cancer? Multiparity. So women who have a high number of children, their risk of developing ovarian cancer is actually less. Also, if a woman has a child after the age of 35, it's also noted to be protective for her. The use of oral contraceptive is also protective. If a patient has used oral contraceptives for 5 years, it decreases her risk of ovarian cancer by 50%. Tubal ligation. So in patients that have decided that they have completed their reproductive desires, you can decide to have a tubal ligation or actually just removal of the fallopian tubes. Reason that this is protective is that there was recently a meta-analysis just on the 6th of September that was published, showing that patients that had a bilateral salpingectomy, removal of the fallopian tubes, their risk of developing ovarian cancer was about 80%, was decreased by about 80%. So this is something that can be done even at the time of a hysterectomy, if it is that the patient is having a hysterectomy for a benign reason, fibroids or just heavy menstrual bleeding. Their tubes can be removed in a young patient, leaving their ovaries present so that she does not now then go through menopause. Bilateral oophorectomy. So in patients that have the BRCA mutation, a bilateral oophorectomy is considered a risk-reducing surgery once she has completed her reproductive desires. Breastfeeding is also considered to be protective. So the cancers affecting the ovary, they're broken down into 3 histologic types. They can be epithelial, ovarian germ cell tumors, sex cord stromal ovarian tumors. This talk will basically focus on the epithelial tumors because that's the most commonly seen type of ovarian cancer. As you can see, the epithelial ovarian cancers account for 70% of this pie chart. In terms of the other types, you have the endometrioid, which is just 10%, mucinous. The mucinous is 3%, but they can be actually metastatic from the GI tract. So always want to make sure that this is just primarily from the ovary and not a mucinous. Clear cells can be very aggressive and they are not always responsive to chemotherapy, but the clear cells only accounts for 10% of the ovarians. And high-grade serous is almost 70% of the ovarian cancers. Just a picture showing an ovary along with sites as to where these ovarian cancers are likely to have originated based on whether they are epithelial or they are sex cord stromal or your germ cell tumors. in terms of cervical cancer, because, Cancer Society, we go to the different family islands and women when they go for their well woman's visit, we talk about doing a pap smear as a part of screening for cervical cancer. So what's the screening for ovarian cancer? There is actually no reliable screening tool for ovarian cancer, again, which is why it is considered the silent killer. Patients with hereditary breast ovarian cancer syndromes, these patients can be followed with a pelvic exam, pelvic ultrasound, and CA-125 levels. However, CA-125 is non-specific, because I put this table here just to highlight the other factors that can cause an elevated CA-125 level in a patient. So it's not always that having an elevated CA-125 indicates that the patient has an ovarian cancer. Some of the symptoms of patients with ovarian cancer, again, which is why the disease is diagnosed so late, because the symptoms are really non-specific. So patients that have bloating, early satiety, loss of appetite, urinary urgency, may have pelvic or stomach pains, unexplained weight loss. So particularly patients that have unexplained weight loss, but yet still they're noticing that there's increase in their abdominal size, then that's cause for concern. Patients with fatigue. So this is just two pictures demonstrating how a patient with an advanced ovarian cancer would usually present to the doctor. Picture here on the left is that of a patient with increasing abdominal size or increasing abdominal girth, and likely that this patient has ascites, so explaining their increase in abdominal size. This photo here is showing what we call a Sister Mary Joseph nodule, again, seen in patients with a late presentation of their ovarian cancer. Another classic finding would be that of pleural effusion. So these patients would normally present with significant shortness of breath. And when you do the chest x-ray, there is pleural effusion, as evidenced by the whiteout on this chest x-ray. What are some of the investigations that can be done after you've presented to the physician with an increasing abdominal size or some of the more commonly seen symptoms? Tumor markers. So yes, mentioned that CA-125 is non-specific, but it is one of the tumor markers that is commonly ordered for patients. LDH, HCG, alpha-fetoprotein, these are more commonly ordered in patients that are of the reproductive age group. And just because these tumor markers would be more specific to the germ cell tumors or sex pod stromal tumors that are commonly seen in patients of the reproductive age group. CA-125 can be normal in an early stage epithelial ovarian cancer. So having a normal CA-125 does not say that the patient does not have an ovarian cancer. And ovarian cancer will only be diagnosed most times at the time of final pathology, when the specimen is then removed. Other things to do would be imaging. So performing the pelvic ultrasound scan that would show features that are suggestive of a malignancy. So is the mass solid? Is there some cystic and solid components? What's the size of the mass? Is it involving both ovaries? All of those are features that would be looked at by the radiologist. Again, after having the pelvic ultrasound, a CT scan would then be done for further staging of the disease, just to then now be able to see if the disease is just confined to the ovary or what all organs are involved, and also being able to assist in treatment planning. Because if this disease is widely metastatic, then treatment may not just be primarily surgery, but there may be neoadjuvant chemotherapy. An MRI can also be done in terms of staging patients with an ovarian malignancy. However, MRIs are usually cost prohibitive given the cost of them, so not commonly done, but they are very much so sensitive and specific for ovarian malignancies. Again, just a picture depicting the various stages of ovarian cancer and where the disease would be when patients have the various stages. So now going on to management, what all management options are available to patients that have now been diagnosed with an ovarian malignancy. When we look at treatment, as I mentioned, we look at the various aspects of the disease, the stage and the grade of the cancer, type and size of the tumor. All of these would determine the treatment options that are available. Can all of the tumor be removed safely at the time of surgery? Is there ascites present? The patient's age and their overall general health. Is this a patient that is 70 and very active, or is this a 50-year-old patient with multiple comorbid illnesses, hypertension, heart disease, diabetes that is uncontrolled? All of these are things that we would evaluate and look at when deciding on a treatment plan for a patient. And also whether or not the cancer has just been diagnosed or if this is a recurrence of the disease would also factor into the treatment. So at the time of surgery, the things that we would do would be washings to be able to send that to pathology, removing the ovaries. If it is a patient that is just having a fertility sparing surgery, then it is just removal of the affected ovary. Infracolic omentectomy, random peritoneal biopsies, biopsies of all adhesions and lesions, along with lymph node sampling and appendectomy. In patients that are not for fertility sparing surgeries, then TAHBSO is the standard. So neoadjuvant chemotherapy, mentioned it earlier, and it is also something that is commonly used in breast cancer and sometimes in patients with colon cancer. It is the giving of chemotherapy before definitive surgery. And the reason for this is to decrease the perioperative morbidity and mortality to the patient. Clinical studies have actually shown that survival is similar in patients that receive neoadjuvant chemotherapy compared with patients that will have upfront surgery followed by their adjuvant chemotherapy. Also, in patients that go on for neoadjuvant chemotherapy or that have neoadjuvant chemotherapy would be poor candidates for surgery upfront because of their coexisting conditions or poor performance status. Also, there are certain criteria that we would look at based on the CT scan or MRI, whether there's any features that suggest that this disease is widely metastatic and may not be able to be removed all at one time. Then these would be patients that would meet criteria for neoadjuvant chemotherapy, even in a otherwise healthy patient. What does chemotherapy for ovarian cancer look like? So chemotherapy for an ovarian cancer patient is that of carboplatin and paclitaxel. Those are two of the more commonly used drugs, and this is also dependent on the histologic type of the ovarian cancer. So carboplatin and paclitaxel are commonly used in patients with epithelials. So your high-grade serous or even low-grade serous ovarian cancers will be treated with carboplatin and paclitaxel. The number of cycles will also depend on the stage of the cancer and if neoadjuvant chemotherapy was given to this patient. So patients that would have received 3 cycles of neoadjuvant chemotherapy after the surgery may just receive an additional 3 cycles of chemotherapy, or sometimes may be given an additional 6 cycles to complete 9 cycles of chemotherapy. Avastin is also a form of chemotherapy that may be added to the treatment protocol, just depending on the stage of the disease and the histologic type that the patient has. Radiation. It has a limited role, unfortunately, in patients with epithelial ovarian cancers. And the reason being that there's increased toxicity to bowel, bladder, kidney, and liver when radiation is used for these patients. So commonly radiation is not an option for patients. Maintenance therapy. There's 3 maintenance therapy options available locally, those of Avastin, olaparib, and niraparib. Olaparib and niraparib are the PARP inhibitors that are available. Avastin is a VEGF that is available locally to patients as a maintenance therapy. Avastin can be given for an additional 12 months, and it is given in an IV form. The PARP inhibitors are given orally, so it's a tablet that the patient would take daily for 2 years after diagnosis. Olaparib is specific to patients with the BRCA1 or 2 mutation. Now, whether that patient has the mutation on their tissue or it is that they have a germline mutation, being that the mutation is within their blood, they can qualify for the use of olaparib. Patients that do not have a BRCA1 or 2 mutation would then be placed on niraparib for maintenance therapy. Maintenance therapy, I will qualify by saying, is only offered to patients with an initial diagnosis of stage 3 at the time. The PARP inhibitors can be used in the recurrent setting for patients. So if a patient has a stage 1 or 2 disease and they reoccur, they can be treated with chemotherapy for 3 or 4 cycles and then offered maintenance therapy with a PARP inhibitor. Talked about fertility preservation, or what can we do in our younger population for patients that do have an ovarian cancer, an ovarian mass. Standard of care for these patients would be that of unilateral salpingo-oophorectomy, leaving the uterus and contralateral tube and ovary, provided that they are grossly normal, doing omentectomy and lymph nodes, pelvic and paraortic lymph nodes. Sometimes, even with fertility-sparing surgeries, it may be that the final pathology shows that the omentum is involved or the lymph nodes were involved, and then the discussion is whether or not to proceed with completion surgery, meaning now to go back and take out the uterus and the contralateral tube and ovary. So in a patient that has had fertility-sparing surgery, what's the risk of congenital anomalies to the unborn fetus? Unfortunately, there's minimal data to say that there is increased risk associated with receiving chemotherapy in these patients. Borderline ovarian tumors. These are commonly seen as well, and it's a group of ovarian tumors that not quite sure should these patients receive chemotherapy at the onset of their diagnosis, but most times we do not give chemotherapy because these are tumors that have a low malignant potential. They can reoccur in 10 to 15 years. And when they do reoccur, then there may be malignant changes present. Borderlines do present in younger population. So because of this is why most times the surgery would be that just of a fertility sparing surgery and not that of a completion surgery. What does follow-up for patients diagnosed with an ovarian malignancy look like? Follow-up would mean that of ensuring that the patient has responded to treatment and looking for any evidence of recurrence of their disease, or even if there is persistence of the disease after they have completed treatment. Most patients would be seen every 3 months, initially for the first 2 to 3 years, and then every 6 months, and then yearly after that. The follow-ups would be that of a physical examination, along with if the initial CA-125 was elevated, then to follow with their CA-125 levels. If the CA-125 shows an increase, then the patient would likely be ordered to have imaging to determine where there is a recurrence of the disease at the time. So again, what's the survival of patients with ovarian cancer? Patients with a stage 1 have a 95% survival. So 95% of the patients will be alive in 5 years after their diagnosis. Stage 2 is a bit better. When we get to stage 4, we see that close to 20% or just about 20% of the patients are likely to be alive at 5 years. Palliative care. Palliative care is something that should be discussed at the time of an ovarian cancer diagnosis, and it is not saying that patients are terminal. Palliative care is looking at involving all persons within the healthcare system to ensure that the patient is home as much as possible, because patients with an ovarian malignancy can commonly represent to hospital with reaccumulation of acidic fluid. They can sometimes present with malignant bowel obstruction. These are sometimes symptoms that can be managed at home with the right supports. So if palliative care is involved early in the process, then patients can actually stay home, be with their families, as opposed to being in the hospital where they're away from their family and the things that they care about. So at this time, I will take any questions, comments. I know it was a lot. I'm sorry.
Anyone with questions, feel free to unmute your mic and ask the question. Otherwise, if you put it in the chat, I can read it out for you.
Excuse me, I have one, Jane Stringfellow.
Go ahead.
I took the BRCA1 test. Is this something you take one time, or can you take it again maybe in subsequent years?
So it is something that you take once, because if it is that you have the mutation, then you have the mutation. If you don't, it's not very likely that you will develop the mutation.
All right, thank you, Dr. Bowe.
No problem. Now, just to also clarify, patients may not have the BRCA mutation in their blood or saliva. There may not be a germline mutation. But if you have a breast malignancy or breast mass, or even ovarian cancer, there can be a mutation within the tissue itself. So you can have what we call a somatic mutation. That's still having the mutation, but it's not that you have the mutation within your blood system, and it's not that your family would be at increased risk of having the mutation.
So are you saying that if you took the BRCA1 for ovarian cancer, you would have had to take it for breast cancer?
No. So if you do the germline testing and your germline testing came back negative, right? Then that means that you don't have the genetic mutation, and your family is not likely to have it, unless you have some family history that is very strong. But if you do now, several years later, have a breast cancer or an ovarian cancer, that can be tested specifically for the BRCA mutation.
Okay.
Is that all right? Better?
I understand. I get it in a greater sense because my sister had ovarian cancer and passed just this year. But when I went in to my doctor, their concern was that it was not mother and father child. It was same mother, but not same father. And they felt like that factored in to me not having ovarian cancer in the future. Does that make sense?
Understood. So BRCA is, and I did not mention this because I didn't want to kind of make it too much, but the BRCA mutation is an autosomal dominant. So it is inherited where if one parent has it, the other one does not have to have it. but it can then now come down to 50% of those children, 25% of those children. So because you don't have the same mother and father, it can be that if it was that you shared same mother and separate fathers, then her father may have had the BRCA mutation.
All right, thanks, Dr. Bowe.
You're welcome.
So there's a question in the chat. Have you seen this type of cancer presented in younger women ages 20 to 40?
So particularly, we do have ovarian cancers in younger population, right? Those would be more of the germ cells or the sex cord stromal tumors. The epithelial or the high-grade serous is usually not in that 20-year-old age group, but you can see it in the 30, 40-year-old age group, yes, and that would most times be as a result of the BRCA mutation.
Okay, another question in the chat. What would be the role of the primary care provider in the screening for cervical cancer if the patient has recurrent positive HPV with pap smear but no symptoms?
Role of the primary care provider in screening for cervical. So most patients with cervical cancer do not have symptoms. When symptoms are present, they are usually late symptoms. So if this patient has recurrent positive HPV, then she should have been vaccinated. There should have been some form of further testing done for this patient, right? In terms of, okay, she's had a pap smear, maybe it was normal, but because she's HPV positive and you know that it won't change, but she is HPV positive, then you can go on to now doing colposcopy on this patient to see if there's something that needs to be treated. I hope that answers the question.
Okay, one more. Referring to ovarian cancer, can you explain again the follow-up after chemotherapy? If you have had the tumor removed, how do you know if it recurs?
So again, going through the follow-up of patients with a diagnosis of ovarian cancer. After patients have completed their surgery, chemotherapy, if necessary, based on their stage, then they will be seen every 3 months by their gynecologic oncologist. At those visits, we would ask specific questions along with examine the patient. If their CA-125 level was elevated at the time of diagnosis, that also will be followed. So these patients will be asked most times to have a CA-125 before their visit so that we can review that. If it is that there's a CA-125 elevation or they're having some specific symptoms, imaging may then be ordered to look for a recurrence at that time. And so that's how you would really know if the disease is reoccurring.
I have a question, I guess, when you showed the pictures, the one with the, I guess, the protruding abdomen, and then the second one that looked almost like a sore. So that actually penetrates or comes through the skin out to the outside?
So that is, yes, ma'am. So that is what we call a Sister Mary Joseph nodule.
Right.
That comes, that's okay. So that comes through the umbilicus out onto the skin. Yes, ma'am.
Is that common?
We do see that. Yes, ma'am. It's more commonly seen in patients with cervical cancer, but yes, you can see it also in patients with ovarian cancer.
Okay. Okay. Anyone else have any other questions they want to ask or put into the chat? Okay. All right, then. If there are no other questions, Dr. Bowe, I would certainly like to thank you for your presentation tonight. Lots of medical terminology there, and but I think you did a good job still trying to get the message across. I guess it's very alarming that there's no real indicator, nothing that really kind of flips a switch to say go to a doctor. I guess so it just kind of follows the know your body kind of a thing, and when things change or seem different, see a doctor. Is that the general?
That is a general rule. You know, you are your biggest advocate, you know your body. And yes, because the symptoms most times are non-specific, then sometimes physicians will say, okay, this is likely to be GI related. You may have reflux and give you medication for reflux because that's what most of the symptoms present as. But again, if it is that you are finding that you're having to go to multiple physicians and the symptoms are not resolving, then yes, you may need to seek care, continue seeking care until you get some answers, unfortunately.
Good evening. I just like to say that I'm a stage 4 ovarian cancer patient. And when you talk about symptoms, from 2019, I've been seeking medical for my stomach. I was having stomach issues. And unfortunately, I've been getting gas medicine for my problem, which was then cancer. And I was really concerned about that because if I'm going to the doctor every other month, every other week for the same problem, no test was done. When I said what it was, so I was just getting gas medication until 2022 when I really was diagnosed. So it's hard, but God has been good to me.
I am sure it has been hard. And yes, you can testify that, yes, the symptoms, because they are so non-specific, most physicians will, yes, like you rightly said, give you medications to treat reflux and explain it away as such. Yes, ma'am.
Something else in the chat. After age 65, if you have had a partial hysterectomy, are you advised that you do not need a pap smear? What then gives you protection for the ovaries and cervix?
So patients that, and I'm assuming that when you say partial hysterectomy, it's meaning that the cervix was not removed at the time of the surgery. So if a patient had a hysterectomy and their cervix is still present, yes, they still need to continue with their pap smears. Now, the US guidelines do recommend that at the age of 65, if all of a patient's pap smears were normal for the last 10 years, then she can discontinue screening at that point. In terms of your ovaries, if your ovaries were left at the time of the hysterectomy, again, there's nothing much that can be done. It would just be to follow if there's any symptoms that the patient has.
Okay.
Hi, so with that, Dr. Bowe, so you're saying even though you have a hysterectomy and your ovaries are still there, chances are you can get ovarian cancer?
If your ovaries are there or not there, I just want to make sure that I'm answering.
If your ovaries are still there, like the partial hysterectomy that the lady had mentioned, but your ovaries were kept.
So then you would have the symptoms that we discussed in the presentation. Those would be the symptoms that you would present with at the time when you now have an ovarian cancer.
Like the other lady who mentioned about giving gas medication. If you're not one of those who are prone to have acid reflux or gas, and this symptoms started and it persists, can you ask the doctor to maybe run another test or something rather than just accept the gas medication and just walk out and say, hopefully this will work? I mean, because, we know our bodies, and, some persons plague with acid reflux and some persons never. And then all of a sudden you develop it, not just always let doctors always say gas medicine. If you know your body, you have the right to say to them, I think there is something else going on. Is there another test, or there a test that can rule out that this is not gas? I find sometimes that we as patients, we're afraid to ask the doctors questions about ourselves. And we need to start getting more comfortable with saying to the doctor, this is something that hasn't happened to me before, and I think I need, a little more testing. And if that doctor refused to do it, then I think you move on to another one who would give you that testing rather than just accept okay, it's gas, okay, it's this, okay, it's that, because we have too many persons now, when they find out about their symptoms, it's already in the latest stage because of, just accepting.
Yes, ma'am. So
that was a question and a lot of comments. Sorry.
That's okay. That's okay.
I didn't want to take up too much time, but that's exactly what I did. After going to the doctor numerous times, the last time I went, I told the doctor, I cannot take this medication anymore because I don't think it's gas that I'm dealing with. I said, is there something else that you can do? I said, I cannot go back home because I'm a person, I know me, and I've been going and going and going, and that is the result that I was getting until I said that. And then I was told to go to another doctor. And that is the time when I went to the other doctor, I made my appointment. And after going to my personal gynecologist, that is when we found out and discovered that I was already at a stage 4 cancer.
So I was going to highlight, yes, the point of a well woman's visit, right? Every female should have gynecologist, somebody that you visit at least annually, if not annually, every other year. And with your gynecologist, they should know your family history, because your family history is important. Do you have anybody in your family with breast or ovarian cancer that we need to be concerned about, especially in the Bahamas where there is such a high BRCA mutation rate? So you need to know that, because then even though there is no reliable screening that is going to diagnose an ovarian cancer early, at least if you're seeing somebody, they can then recommend having pelvic ultrasounds fairly often to make sure that there is not something that is going on. And if you're going to your gynecologist, not every year, but every other year, and you're having, yes, the reflux symptoms, then that gynecologist would likely say, let's go ahead and order a pelvic ultrasound scan just to make sure that there's nothing going on with your ovaries or there's nothing going on with inside of your pelvic area that we need to be concerned about. So we need to get comfortable with going to our physicians, not just because we are having symptoms, but because we're going for our yearly annual. And in going for your yearly annual, then you talk about things that may have been a problem before, but you're not having the symptom right now. And then your gynecologist or your primary care provider may say, okay, if you have this symptom again, because you've been having this for several months, then call me or call the office and we can arrange for further testing to be done. But unfortunately, by just going to a physician when you have a problem or you're having a symptom, most times physicians will just be more problem oriented and trying to get to the root of that problem and not looking at the comprehensive package of the patient in the front of them.
Okay, anyone else? Any other questions, comments? Okay, well then, once again, Dr. Bowe, thank you very much for your presentation. And we look forward to seeing or hearing from you again sometime soon. I'm sure we'll see or hear about you in our clinics. So we thank you for that work that you do as well.
Thank you very much.
Erin, any other announcements or anything else we need to be aware of? Next month's meeting will be October, is it 5th, Erin?
October 10th.
October 10th.
Yeah.
Sorry.
Yeah.
As you all know, that's Breast Cancer Awareness Month. So I'm hoping we'll have a good attendance like we have had tonight. Would like to see all or most of you again next month. And thank you for joining us today. And after a long summer break, good to have you all back. So thank you once again, Dr. Bowe, and thank you to all of you, and stay safe, and we'll see you again next month. But in the meantime, stay tuned into our website for whatever else is going on. October is usually a very busy month, lots of activities, lots of presentations and so forth. And as Erin said, get your orders in early for your shirts, your leggings. Be armed and ready.
Yes.
Good to see you all. Anything else, Erin, or?
No, that's it. That's it. Very, very nice talk tonight. Learned so much. You know, you think you get away with one thing, but there's something. But you know, as the Cancer Society, they stand on early detection or even prevention. So, you ladies, you all know your bodies. Nobody know your bodies like you do. And, get it checked. NHI now have where you can have your physical done. And it's a fraction of the cost. So take advantage of that. But get your yearly screenings. And this would help that if there is a diagnosis, it's in its early stage and it's more treatable. But thank y'all so much, and we'll see y'all next month.
Okay, thank you, everyone, and good evening.
Good evening.
Good evening.
Good evening.
Good evening from Grand Bahama. Hi,
Good evening.
President Wilson, and hi, Erin.
Hi, how you doing?
We're fine. We're just ending our meeting, so we're saying hi.
Oh, hi.